Hey Pen, so I thought I would make these little videos, well I'll make this little video, and see if it helps with, understanding, decreases the stress about understanding the cardiovascular system. Maybe it won't, maybe I'll just be repeating a bunch of stuff you already know, but I'll just go through it and hopefully it'll help. So the CV system, I actually have the book. I have it on Kindle now. I hate technical books on Kindle because I like to be able to flip pages back and forth and all that kind of stuff. I might actually order it. I know you think I'm crazy, but it's okay because I am just a little bit. So first thing you need to do, you know what I'm going to say, right? Take a nice deep breath. Hold it at the top. Hold it. Exhale slowly. So, you guys didn't do the blood system, I know, or you told me. So, just to touch on that real quick, plasma, what we would call blood, has a liquid portion or a fluid portion called the plasma, and then it has some solutes in it, and one of those, or particles, or one of those things are red blood cells, which have hemoglobin. And hemoglobin carries oxygen to the cells and carbon dioxide away from the cells. Red blood cells, all that. There's other things that they do and other components, but just keep it simple like that for this explanation. So basically, the heart's job is to transport oxygen and other nutrients to every cell in the body, right? Because every cell in the body must have oxygen to function. And cells become tissues, and tissues become organs. So every tissue, every organ, every cell has a job. It has a function it could do. A muscle cell, its job may be to stretch. Excuse me. A stomach cell's job may be to secrete acid into the stomach. A heart cell's job is to beat, contract. So, but every single cell, so you think it's like down to the tiniest living organism, needs oxygen to survive. And of course, being an anesthesia provider, oxygen is like my favorite thing. It's like, I used to have a friend that said, get in the ocean cures everything. To me, oxygen cures everything. Oh my God, give them some oxygen. So, the heart's main job is to transport oxygen and other nutrients, and then to take waste products from the cells, the very same cells, to be excreted through the venous system. I always think of the left and right sides of the heart. So the left side is always red because that's the arterial side, and oxygenated blood is bright red, whereas blood that does not have oxygen from a vein is a darker color. Hard to tell when someone's bleeding because it's exposed to the air, but that's when you see something pumping. Sorry, allergies are killer here right now. When you see something pumping on television or show or something like that, that's an artery, because arteries, actually, the vessels themselves pump. Okay, I'm getting ahead of myself. So the cardiovascular system's job is to transport, replenish and excrete nutrients, etc., from the cells of the body. It's in the central chest, under your sternum, in your mediastinum, and it's kind of tilted off to the side, and most of the I think it's like 2/3 or something. I think that's a question you guys have to know the answer to. I don't. Is on the left side. So like when they're doing heart surgery and stuff, the retractor is on the left side. And the heart is divided into 4 separate chambers. The atria are the 2 top chambers, and the ventricle are the 2 bottom chambers. The atria receive blood, and then they let blood go down into the ventricles, and the ventricles send blood. So the atria are kind of the receiving chambers, and the ventricles, actually, you guys have a word for, sending out. There you go. The sending out chambers. The ventricles, which are the ones that pump, the right ventricle pumps blood into the lungs, and the left ventricle pumps blood into the aorta. They're the ones that actually are pumping it into something, whereas the blood is just kind of coming into the atria, and it kind of drains, through the valves between the atria and ventricles. So there's different layers of different kinds of tissue, right? There's the muscular tissue, there's the part of tissue that's on the inside, there's the pericardium, there's the endocardium, and you probably have to memorize those layers of tissues. I think there's 3. I used to know them. Myocardium, pericardium, epicardium. Anyway, is that right? So, there's endocarditis, there's pericarditis listed in your book. Itis means inflammation of. Inflammation usually occurs for one of 2 reasons: either infection, bacterial or viral infection, which causes irritation and disruption of the tissue, or trauma, which also causes irritation or disruption of the tissue. So that simply means inflammation of. So inflammation of those different layers. And the septum, I told you, well, maybe I didn't say, but down the middle between the atria, the left side and the right side, is a septum. And then on the outside, there's a pericardium, which your book says, which is a very apt description, is the pericardium is like the skin on an apple. So it's really close. So there's no real space. I don't know if anyone has ever gotten a palatal injection when they've gone to the dentist. The dentist had to put numbing medicine in the roof of your mouth. I refuse to have them. I would rather have the pain. I swear. Sorry, I shouldn't even be saying that, especially anybody with dental phobias. But the reason it hurts is because there's actually no space between those tissues. There's what they call a potential space. So when they put that numbing medicine, it's actually stretching the tissues apart. So that's what tamponade does when the pericardium fills with fluid and just starts filling with fluid and pressing more and more, because you think the muscular part of the heart pumps, and each time it's going to fill more and more and more with fluid till it's restricted. The heart can't do its job. And the heart's whole job is to pump. The heart's whole job is to be a muscle. So whenever you interfere with the muscular ability of the heart, you're going to have problems. Its ability to contract, either by restricting it somehow with fluid on the outside, like in cardiac tamponade, or by not providing the tissue with not enough oxygen. Again, every cell must have oxygen. When you think about putting a rubber band around your finger, it won't last for very long. It hurts. And if you left it on there for any period of time, that finger would die. The tissue would die because it needs oxygen to survive. You wouldn't be able to stand the pain, but the tissue would die when you're running or doing something where you get that cramp in your side. It's because you're unable to supply enough oxygen to that muscle for it to do what it is you're asking it to do. So if you run, if you train, if you exercise that muscle that is your heart, and you make that strong, it's able to keep up with the increased oxygen demands of your body, of an athlete's body. But even you can see how when someone has heart disease, how that affects their ability to move, to do the things they need to do, to walk across the room, to get up out of the chair. right? Because to get up out of the chair, the heart has to be able to pump enough oxygenated blood to those muscles that lift them up, and often it's just not up for it. Okay, sorry, getting off track. I tend to go off on tangents. You know this, pen, and I apologize. If you guys can fast forward, you can do that. Okay. So we talked about the location of the heart, the different bits of the heart, CPR, which I'm sure you guys will learn. I'm sure you'll have to be BLS certified. So now there's the 4 chambers, myocardium, endocardium. Right, so it talks about inflamed endocardial linings, right? So endo inside the heart, the linings of the heart. So whenever you get an infection or you get trauma or anything, I'm sorry about the glare. I'm not sorry enough, of course, to close the curtains, but it can cause rough spots on the tissue, like an infection or like trauma can. If you think about old pipes or whatever, that kind of, the old cast iron pipes used to get the rough parts. And that can actually cause your body to release clotting factors. So if you have any kind of inflammation or atherosclerosis in your coronary vessels, which we still haven't gotten to yet, I know I'm getting ahead of myself, you can form a clot against this rough tissue. Okay. The coverings of the heart, pericarditis. Okay, the heart action, the heart pumps, and it pumps rhythmically. So the atria pump together, and then the ventricles pump together. Okay, when the kind of more like that, as opposed to, it's more like that. And when you're measuring someone's blood pressure, what you're measuring is the pressure of the blood in the arteries. The top number is the pressure in the blood in the arteries when the heart is contracting, so that's going to be a higher number. And the lower number, or the down number, or the diastolic number, or diastole, is when the heart is relaxed. So that's the pressure in the arteries when the heart is relaxed. So that's why having a higher bottom number is more significant than having, especially if you're taking care of a patient who's in the hospital or whatever, because, you know, people who are in the hospital, people who are having surgery, they're nervous and rightfully and dehydrated and all kinds of other things. Excuse me. So, but you know, somebody who comes in who normally has a blood pressure of 120 or 118 and they have a blood pressure of 140, 150, even 160, I wouldn't worry. Even 170, I probably wouldn't worry, because I just think it was anxiety. As long as their bottom number was low 80s or below 80. But when people are just walking around or sitting down and their bottom number is 90, you know, they probably have heart disease. They certainly have atherosclerosis, which is when you have, if you have a high cholesterol, or if you're diabetic, or if you're running around with a high blood sugar all the time, what happens is your body doesn't know what to do with these extra substances. So they kind of, they kind of lay down a layer of themselves along a layer of this like lipoprotein stuff, lays on the inner walls of the vessels, including the heart vessels, which are really, really tiny, so it doesn't take a whole lot to block them. But it lays down, and over the years, you know, a vessel that used to be like this is now like this. So why the pressure is high is because you're moving around the same volume, right? But through smaller pipes. So the pressure has to increase, right? Think about that for a moment. Okay, so that's why you worry more about the bottom number. Now, obviously, if someone's top number is really high, you worry about that too, because you don't want them to have a stroke. Okay, so that's systole and diastole. So there's valves. There's AV valve, atrioventricular. I don't know if you guys have. I think I asked you this, Penn, but I forget what your answer was. If you guys had to take a medical terminology course, I mean, knowing these prefixes and suffixes and everything, telling you they will save your life. So AV valves is obviously between the atrium and the ventricle. And the valve's main job, actually, I wrote that down, which is a great, actually, thing in your book. The heart's job is to be, in order for it to be efficient, it must be rhythmical and directional. So the valve's job is to prevent backflow, because the heart, the fluid needs to keep moving in one direction. It can't be, here and then forced back up and all that kind of stuff. So, when the atria fill, click, those valves shut, because they have to have a little bit of pressure to go into the ventricles. So the ventricular, those valves open, the AV valves open. The fluid goes into there. When they fill, those valves close, and then the ventricles contract with, a lot of muscle behind them, especially the left ventricle, right? So you don't want any backflow, because any backflows is going to decrease what your output is. And the whole way that cardiac function is measured, not the whole way, but yeah, pretty much, is through cardiac output. Is the heart, if 100 mLs are in the left ventricle to be delivered to the body, how much of that is being delivered to the body? Okay, but I think a cardiac output is going to be a different number than EF, which is the number that I love, but I digress. So it must be rhythmical and directional. So the valves keep it moving in the right direction, and the electrical system keeps it rhythmical. Okay, because there has to be enough time. The rhythm has to give enough time for the atria to fill, and then the ventricles to fill, and then for them to deliver. Without valve, so we'll get to that. So that's the valves. I mean, you'll have to memorize those. And then there's valvular disorders, incompetent valves, which means that you're going to get backflow because they don't close completely. And then stiff or stenosed valves, which can sometimes mean that they don't open enough to get the blood flow. Right, they're narrower, so it slows the blood flow into or out of one of the chambers, right, because it's all stenotic. Rheumatic heart disease, mitral valve prolapse. So an echocardiogram is a really nice way for them to look at valves. Again, I mean, you won't have much to do with that. No one expects you to read an echocardiogram, or, if somebody tells you something's incompetent, I mean, it's pretty obvious what the story is. If they say they have an incompetent valve, that means there's backflow. How incompetent is it? That's the question. I mean, are they getting any cardiac output? Everything in the cardiac system has to do with cardiac output and its ability to deliver blood and oxygen and nutrients to the cells. Heart sounds, again, something, they'll probably play you a tape, or, and this talks about, the blood coming in. Again, this is some stuff that you have to memorize. You don't need me to go over it. It's just stuff you have to memorize. So how the circulation goes is, so let's say it comes in. We'll start at the right atrium. It comes in through the right atrium. Okay, blue, right, because it's on the right side. It comes in through the right atrium. It goes, sorry, the camera just went for a second. I hope it didn't go for you, although you could probably hear me. So it goes into the right ventricle. It goes from the right ventricle into the lungs. Now it becomes red because it's picking up oxygen. It drops off its CO2. We breathe that out through our lungs. It picks up oxygen. It goes into the left atrium, into the left ventricle. The left ventricle, the big, strong left ventricle, pumps it out. And it has to pump against the pressure of the vessels, your blood pressure. So it has to be a big, strong muscle with thick muscular wall. And it pumps it out into the aorta, and then the aorta comes down and divides into the femorals and the blah blahs and the blah blahs into smaller and smaller vessels until, there's arteries and capillaries that reach into the tips of your toes and the tips of your finger and the tips of your ears. Your heart gets filled from the top, like if the aorta's here and then the left ventricle's here, your heart kind of gets filled right at the top where that meets. So your coronary arteries get perfused first. Well, blood gets sent that way. Hopefully they're perfusing. But so it goes through the arterial system. As it does that, it takes nutrients and my favorite drug, oxygen, through the system, drops it off to every cell that needs it, picks up waste products and CO2, then moves into the venous system. Now, the arteries have muscular walls, so there is actually a pressure in your arteries. So it's like when you give someone epinephrine or adrenaline, right? What that does is that makes everything clamp down. So it actually makes your arteries get smaller. So that if you don't have a blood pressure, right, it will give you one. Epinephrine will, as long as your heart's beating. Okay? It clamps down all the vessels. So you have the ability, other vasodilating drugs, like drugs you would use for somebody with high blood pressure, certain classes of drugs you use for somebody with high blood pressure, are arterial dilators. So that makes the arteries dilate. You can't have that kind of control over veins. They don't really have a muscular layer, and they move the blood through the body basically by gravity. There is a tiny bit of pressure. I don't remember the numbers. Somehow 40 sticks in my mind, but I don't know. You won't have to know that anyway. But it basically moves through your body, through the venous system. The blood moves mostly by gravity. So, if you've come home with swollen feet or achy legs or whatever, and if you haven't yet, welcome to nursing. I know you have, Pen. And you come home and put your legs up the wall, some of the fluid drains out and it feels a little better. There's not as much pressure because there's not as much fluid in your feet. So pulmonary circulation is through the lungs, right? Pulmonary lungs. And the systemic circulation is through the arterial system and even through the venous system. Pulmonary system is just the lungs. So blood supply to the heart muscle again. Coronary circulation, it gets it kind of first. And considering that they supply the organ of life, pretty much. I mean, you think about your heart starts beating when you're a fetus and doesn't stop until you're dead. That's pretty fucking awesome. So, considering the importance of it all, the coronary vessels, the coronary arteries are actually very thin, like a little bigger than the diameter of like one of those round toothpicks. So what we used to do when we did, they still do it, but we more frequently when someone had, or all the time actually, way back in the day, because I'm ancient. When someone had coronary artery disease, they did what they called coronary artery bypass graft or surgery or CABG. So what they would do is say this is the coronary artery, and that clear bit right here is the blockage. So they would take a vein from someone's leg, which is why they have a scar on their leg. They take a piece of vein from someone's leg, which again is going to mean their leg doesn't drain that well, venous drainage, because it's a fairly good sized vein. But anyway, they take a piece of vein, they bring it up to the coronary artery, and they sew one end of the vein here past the blockage on this side, and one end of the vein here past the blockage on this side, because the blockage is here. So now the blood flows past the blockage. It bypasses the blockage, right? So that's what we used to do all the time for people with coronary artery disease. Now, they're, interventional cardiology, where they put stents in, they take them to the cath lab, and basically what they do in the cath lab is they put a catheter in through the femoral artery, usually, and through their groin, and they feed it up into their heart, and they inject dye into the coronary artery so they can see, how much it's narrowed, how much it's blocked. It can always, it gives them a percentage. I haven't worked in the cath lab in a gazillion years. I think I was only in there a couple times to begin with. And they can actually put a stent in, which starts out, again, really narrow, really, really tiny, a thin thing of metal, and they feed that up into the coronary. When they get it where they want it, they press this kind of activator, and this is a simplified explanation, but they press this kind of activator button, and the stent opens the blockage. Okay. Sorry, I have to keep looking down, but I'm trying to, follow your book in a certain way. So a myocardial infarction. So again, myocardium. Again, if I didn't say this, the myocardium is the important part of the heart because muscle. It's all about it being a muscle. So a myocardial infarction is a heart attack. It's basically a blockage, either temporary or whatever, of one of the coronary arteries. And I did see embolism here, but there's a few different ways that someone can have a myocardial infarction. One of them is through a clot. Again, when I was talking about, when people have atherosclerosis and they lay that stuff down and it's kind of jagged, kind of like when people get other types of inflammation inside the vessels, it's kind of jagged, and it can cause a clot to form there. So it can be a clot. It can be a piece of plaque, that sticky stuff that I said they lay down in their vessels is called plaque. Sometimes a piece of plaque breaks off in a bigger vessel and comes up and jams in the coronary artery. It can just be a spasm. The coronary vessel has a spasm. So whatever the case, the key factor is, how long is that muscle tissue, that cardiac tissue, that myocardium, how long does it have to how long has it been without circulation, right? So how much tissue has been lost? So you look at someone like Gulab, I don't think lost any muscle tissue because it happened so fast, and whatever caused his blockage. I mean, he had 90% blockage when he went in, but whatever caused his blockage, when he vomited, it kind of caused some kind of chest pressure reaction that moved it along. So, and he used to walk, and he has a lot of what they call ancillary circulation, which means it's like any muscle, right? You can make a muscle bigger and stronger. And one of the ways you do that is when you push it beyond its limits, it actually makes these other little blood vessels out from the other blood vessel, like from a main, say there's a main blood vessel here and you start running, you start getting these little tiny blood vessels. So that, again, advanced concept, don't worry about it. But, you know, he didn't lose a lot of muscle tissue. Now, my mother did, because something was being blocked there, not completely blocking the circulation, but blocking it enough so that tissue suffered. So that's why they talk about CPR. You know, that's why they want to do CPR. That's why they want to keep that circulation going as much as they can, moving blood, especially through the heart, to keep that tissue alive. Because what happens then is if you lose a part of the muscle, so say the heart's supposed to beat like this, and you lose part of the muscle, and now it kind of beats like this, right? So that's going to decrease, again, the most important thing, the output, because the muscle isn't contracting with the force that it used to be able to contract. Therefore, it's not going to eject the same amount of fluid or blood that it used to eject with each contraction. And that's why I say, you know, the EF, ejection fraction, that's the number I want to know. When someone's telling, you know, when I'm getting a patient and they're saying, you know, oh, they have heart disease, they have this, they have that, when's the last time, you know, they got an EF, and what is it? Because that's the fraction of the percentage of blood that you eject each time your heart contracts. And I mean, 70% is really good. We were all I asked a bunch of other anesthesia people, like, what's the highest you've ever seen? I think somebody said 80%. So you're never meant to eject 100% of it. But when it starts to get about, you know, like 70% is great, even 50% is great. 40%, you're like, you know, 50% I probably wouldn't open the fluid up and all that kind of stuff, but 40%. But when it starts to get about 30%, it's like, oops. Sorry, pen. Sorry, pen. New camera. And we're back in the room. So, so that's what I have to say about myocardial infarction. And it's like it's saying, deprived of oxygen, these cells become damaged and or tissue death occurs. Angina pectoris just means chest pain. Coronary bypass surgery, I explained that. A coronary angioplasty is basically what I said about putting stents in. That's an angioplasty. Less invasive than cardiac surgery, like they don't have to cut your chest open. Vessels, you're on your own. So cardiac cycle, which includes systole and diastole. Your objectives are to know the location, size, and position in the thoracic cavity, which you know, the heart chambers. You know what the pericardium is, the heart valves, you know they're there. The major valvular disorders, basically there's two, applied to each valve. Each, depending on which valve it is going to cause a different kind of problem. Right, so say it's a valve that leads from the lungs into the left atrium, right, because it goes right atrium, right ventricle, lungs, left atrium. So say that valve has backflow. Where is that fluid going to backflow into? Their lungs. So if you listen to breath sounds, you're going to hear because the fluid is backing up in their lungs. Okay? Say the valve leading into the right atrium has backflow. Where is that going to build up? The body. Right? So it's more complicated than that. But I mean, the thing is with these classes and with some of these instructors who don't really you get lost in the minutia of it all. So for me, I think that understanding, and when I taught and when I learned, I wanted to just understand the general idea, like get the function without the pressure of memorizing all the stuff. There's going to be stuff you're going to have to memorize. But personally, I think things are much easier to understand and memorize if you know what the hell's going on. So let's see. Normal heart sounds, trace blood through the heart, explain the cardiac cycle. Of the conduction system. So is that where we are now? So the electrical system, which if you went through cells, you went through action potentials and all that kind of stuff. So a cell gets stimulated to do whatever it is that it does, right? Contract if it's a muscle cell, release chemicals if it's a nerve cell. Okay, so the electrical signal of the heart starts in the SA node. Okay, so the S stands for sinus, okay, which is a bit confusing because it's actually in the right atrium. But it's the SA node, so when the right atrium is dictating the beat, it's one of the things that can dictate the beat. It should be the thing that dictates the beat. It's called the pacemaker of the heart, but other things can take over again. So it starts out at the SA node. The SA node sends the electrical impulse to the AV node, so where the AV node be, between the atrium and the ventricle. And then the AV node sends it down these fibers into the ventricle. So that's how the contraction happens. Remember I said it's like so the SA node has a set timing of 60, actually it may be 4200. Don't make me lie. But when they talk about being in, well, that's not true either. Okay, so that's basically the electrical system of a Purkinje fibers, bundle of His, all that kind of stuff. Basically, the bottom line is there's a node in the right atrium that initiates the electrical impulse. There's a node between the atrium and the ventricle that carries that into the ventricles. Okay, and this causes the contractions. And all the cells are electrically linked together, and cardiac cells have something called automaticity, so they can initiate an action potential. They can generate an action potential. Usually you need a stimulation from something else or another cell, like a message from your nervous system causes your, when you say move my hand, that message goes from your brain to your hand to move your hand. These cells in the heart can just initiate an action potential by themselves. That's called automaticity. So the sinusoidal node is the pacemaker of the heart, the AV node, and then the AV bundle and the bundle of His, and then the Purkinje fibers. This all goes, and it conducts an impulse. Like I said, it goes like that. I'm sure she won't ask you how the impulse goes on the test, but that's how it goes. Actually, more like this. Anyway, so an EKG basically measures the electrical signal. And depending on where the leads are, you can look at different parts of the heart and see how those parts are responding. So you can see on a 12-lead EKG, you can see an old infarct, stuff like that. But basically, an EKG shows it has a wave that goes like that, which is a P wave, which says that the message started at the SA node. So when you see a P wave, that little wave in the front, I'm sure they have a picture of it, that little wave in the front, and then it goes like that. That's P, and that P wave, whenever you see that, that's a sinus rhythm. Now, the rhythm can either be slow or fast or dysfunctional, right? Dysrhythmic. So if it's slow, it's going to be Brady, sinus bradycardia. If it's fast, it's going to be tachy, sinus tachycardia. If it's not rhythmic, it's called a dysrhythmia or an arrhythmia, as in without rhythm, right? So if it's not rhythmic, it's an arrhythmia or dysrhythmia. They're kind of interchangeable, I think. So Brady is slow, sinus is fast. So P wave, it's always going to be a sinus rhythm. QRS, okay, that's the ventricle contracting. Okay, they talk about T waves, all that kind of stuff. I'm not sure why you need to know that. The QRS is basically the depolarization of the heart. And cardiac dysrhythmia. So everything, like you'll see, there's a P wave, and then there's a space, and then there's the QRS, and then it comes up, and then there's a little space, and then maybe there's another wave. So everything, like the space between that P wave, and you'll see after a P wave, if you look at it like a normal EKG tracing, you'll see after that P wave there's a straight line. So the difference between the distance between that P wave and when it first starts to go up again, there's a set distance. And the distance is time. Like on an EKG paper, there's all these little tiny blocks, and each little tiny block, oh, for God's sake. I will fix the camera pen. Sorry. And and each individual block represents a period of time. So there can, if there's more distance between your little P wave and when this starts than normal, then it's said that you have a block, because it's not sending the current, because that's a block between the time that the current leaves that one place and can get to the other place, right? Because this is kind of SA node, then it's kind of like AV node, okay? So it's the time it takes the current to go from one place to the other. And if it's longer than normal, then there's a block in the road, in the wiring system, in the electrical system of the heart. So that's what blocks are. And some blocks are just, they're still regular. So what they talk about is what you want to see is, are the ventricles beating rhythmically as well? So if you have a block, is it just taking time to get to the ventricles and then the ventricles beat anyway? Or is that little P wave marching along rhythmically, but then the ventricular wave is all over the place? It's got no relation to the P wave. Okay, that's bad news. That's a third-degree block. That means that really no message is going from the SA node to the ventricles. The ventricles are just going, what the fuck? I should be beaten. Like, why isn't anybody sent? Okay, so that's bad. But there are other blocks, like a first-degree block, which isn't. Obviously, you don't want any block, but you can work with that. So blocks. If there's a block that that is a third-degree block, basically you get a pacemaker, which is a fake, which starts the electrical current or gets the electrical current to where it needs to go. Bradycardia, again, a slow heart rhythm. So you can have a sinus bradycardia, okay? And we're still talking about sinus here, and that of course demands a pacemaker. if it's too slow, because again, rate and volume is going to give you your cardiac output, and of course having a muscle that works. So if the rate is too slow, you're not going to be delivering the amount of blood that your body needs to get oxygen to all its tissues. You're not going to be delivering it soon enough, and maybe not under enough pressure. Tachycardia, again, a rapid rhythm, which is above 100. Bradycardia is below 60. That can affect cardiac output, again, because is everybody, but mostly left ventricle, are they having enough time to fill before they're pumping and emptying again? And if they're not having enough time to fill, if you have a heart rate of 120, 140, 160, people have heart rates of 200, you're probably not getting any cardiac output. Okay, even though your heart's beating fast, it's unable to do its job because everything is dependent on everything else, and rate is very, very important. Not only can it decrease the cardiac output due to not having time of chambers not having time to fill, but a higher rate, like anything, when you increase the use of a muscle, if you're running or you're doing this with your arms, there's a higher oxygen demand. And if oxygen supply is compromised by coronary artery disease and you increase the rate, so that's why they beta block people with heart disease, or beta block makes their heart really can't go fast. It blocks the heart's response to things like adrenaline or epinephrine. So the heart really can't beat that fast, because somebody with really bad heart disease, whose heart rate goes up to 100, 120, would probably have a heart attack. Okay, I'm getting off task again. Sinus dysrhythmia, again, not rhythmic. Premature contractions are usually normal abnormalities. They happen when people are dehydrated or whatever. If they're happening every other beat, or every beat, or if they're happening really, really frequently, and the blood pressure's funky or whatever, but usually, an occasional premature atrial beat or a premature ventricular beat doesn't hurt anything, and it's pretty usual among young children, especially PACs, premature atrial contractions. PVCs more so older people. Fibrillation is when, instead of contracting, the heart just fibrillates, which makes it, of course, a completely ineffective pump. So AFib, again, so if you have something that's supposed to be, the blood is supposed to be moving, and now it's hanging out in this place because these things are just doing this instead of pumping, there's a high chance it's going to clot. It's going to form a clot. And then when you do get a pump, there goes the clot through your system. That's why atrial fibrillation is so dangerous. That's why people who have atrial fibrillation are put on blood thinners so that they don't make clots. I mean, you try and get it so they're not in fibrillation, but oftentimes you can't. So you just treat them so they don't clot. Ventricular fibrillation is what most people die from. That's when the ventricles kind of just going like this, and if it's not treated, and it's all about defibrillation, which is, like when you go into the places and they have those defibrillators, the AEDs, the automatic defibrillators. That's what it's all about, because what you want to do is try to give a rhythmic, you're trying to get the heart back into rhythm by giving it a shock of electricity in hopes that it will pick up and do what it's supposed to do. And that is really the only thing you can do for ventricular fibrillation. We used to do something called a pericardial thump, where you would go whack, which I guess is kind of the equivalent of electrical shock. I think it worked often enough. I never had to do it, thank God. But you want to defibrillate them. and epinephrine, you'll see epinephrine. So AEDs, it lists AEDs. Some patients who are prone to going into VTAC or VFib will have an AICD, which is an automatic implantable cardiac device, I think. Cardiac defibrillator. So if their heart goes into AFib or anything like that, or I'm sorry, if their heart goes into VFib, they get shocked. It's like a pacemaker with a shocker. My mom has that, actually. Atrial flutter, you can study all that. Cardiology, cardiologist, cardiac output. Okay, cardiac output is the volume of blood pumped by one ventricle per minute. It averages about 5 liters in a minute, which is just about an adult's blood supply. I'd say 5 to 6, 7 liters is an adult's blood supply. So cardiac output is determined by heart rate and stroke volume. So heart rate, how fast is your heart going, right? And stroke volume is, with each stroke, how much volume is your heart putting out. Okay, and that's how that's measured. And there's calculations you can do. Okay, this talks about heart rate. It talks about the parasympathetic and the sympathetic. So that has to do with fight or flight, rest and digest. So it's your autonomic nervous system, which means it's a nervous system that you don't control, right? It's not your brain. You can slow your heart rate down, etc. But basically, it does its thing on its own. So if fight or flight, you are walking down a dark street and someone pops out of an alley, right? Your heart rate goes up, and your heart rate goes up so that it can deliver more oxygenated blood to your muscles so that you can run. Okay? Your pupils dilate so that you can see more of what's going on. Your bronchioles dilate so that you can take in more air and more oxygen, again, so you can run, so you can flee or fight. Okay? And when we're anxious, and so your heart rate goes up, your blood pressure goes up, all that kind of stuff. And when we're anxious, we tend to be in fight or flight and not, especially if you're in nursing school, when you feel constantly under attack. But you got to try and calm yourself down and just, so your parasympathetic is the one that controls your digestion and your rest cycle and all that, and slows your heart rate down, whereas your sympathetic speeds your heart rate up. Pupils get smaller, all that kind of stuff. I was going to say something else and I forgot what it was. So the balance between these two systems is what keeps your heart beating at a regular rhythm between 60 to 100. They have reflex bradycardia in here. So this is very involved, it seems to me. I mean, you are not going to be expected. Well, let me shut up. So your body, amazing vessel that it is, amazing machine that it is, tries to maintain a certain pressure. Certainly it tries to maintain enough pressure to perfuse your organs. Now remember, blood has to get into the tiny, tiny vessels in your fingers and toes. So it needs to maintain, and your kidneys and your liver and everything. Okay, so it needs to maintain a certain pressure to this hair is driving me crazy, to make that happen. But it also wants to maintain like homeostasis. So it wants to stay within a certain bit of parameters. So if you say that you give someone epinephrine, like say that I'm in the operating room and someone's blood pressure goes down to 88 over 40 or whatever, and I want to give them a little epinephrine to make their arteries clamp down to increase their blood pressure a little bit, right? Which is gonna give them perfusion, right? Because it's all about getting all that blood to all those tissues. right? If I give them too much, or they're dry, which again is an advanced kind of thing, but what happens is if they're dry, which they usually are, because it's these little old people who have been told not to eat or drink anything from midnight, and they haven't had anything to eat or drink since dinner at 6 o'clock the night before, like not even a sip of water, because they don't want to take a chance, and they're like bone fucking dry. But you know, if they're dry and you give them a little epinephrine, instead of just giving like a nice little squeeze, it's like, because they're trying to clamp onto stuff that's not there. There's no fluid in their vessel. So you might get a bit higher. It might go from 80 to 140. And what happens is say the heart was pumping along at 90 because they're dehydrated, and the heart's saying, holy shit, I need to get some pressure going. I need to get some volume going. So let me just speed up and let me just get a pressure. When the pressure goes up, the heart goes, okay, whoa, that's enough pressure. And then the heart slows way down. And that's called reflex bradycardia. It's everything amazingly, brilliantly works together all the time. That's why it just drives me nuts that you have a teacher who's not into what she's teaching. Because, I mean, this shit is fascinating. Come on. Anyway. Heart medications, anticoagulants, and antiplatelets. Again, platelets are the things that they release to help a clot form. So if people have atherosclerosis, that rough stuff on the inside of their vessels, or if they have a stent, which is a foreign object too, and also, you know, the body reacts like, oh God, it's inflamed, especially for the first 6 or 7 months. TPA dissolves clot. So there's clot busters that they have now. That's mostly for strokes, but for MIs too. So if the person fits the criteria, which means they've never had a bleed in their belly and they haven't had a bleed in their head or anything like that, they can sometimes dissolve these clots with these TPAs. Beta-adrenergic blockers, beta blockers, important cardiac drug. So why is it an important cardiac drug, you may ask? Because remember what I told you about rate. Rate is the biggest deal in being able to protect cardiac tissue, is to control that rate. They're cardioprotective. They give them to people who don't have cardiac disease. You know, beta blockers are, you know, it's discovered that they are really, really, really good for your heart. They're really protective of your heart. So what these drugs do, so I don't know what you guys learned about in cells or whatever. I haven't gone back and looked at that. But cells, depending on what their function is or whatever, you know, they have the cell wall, and embedded in these cell walls are these receptors. And if you think of them as a key and lock kind of thing, only certain chemicals, only certain things are going to fit into their specific receptor. And a good example for that I like to use is insulin and glucose. So say you eat a meal. So your body goes, oh, the sugar's going up. So your pancreas releases insulin. The insulin goes to the cell, goes and sits inside the receptor. The cell opens up, and now the cell's able to accept glucose. Okay, so that's how receptors work. And receptors, I mean, everything pretty much has to do with receptors, certainly drugs. So it basically changes what the cell will and won't do. So you can, with these receptors, you can either block them so that whatever the chemical is that usually attaches to them can't attach to them, right? So you've basically blocked them like a beta blocker, or you can do something that activates them, a drug that activates them, like giving someone insulin, which will activate the receptor to let the cell open to let the glucose in. So there are a bunch of beta receptors on the heart, and those they are receptors for things like epinephrine and norepinephrine, so stimulants, things that make the heart go fast. So what beta blockers do is they block these epinephrine receptors. So even if you get upset, your heart rate's only going to be able to go so high because all your receptors for epinephrine are blocked by the drug that you're taking. So what happens in these, which is why patients can't just stop taking beta blockers, right, is because your body, again, being the amazing thing that it is, goes, what the fuck? I don't have any beta receptors anymore. Like, I can't seem to find any, so it makes more. So say, this is just an example, say that, your heart has 50 beta receptors. And then your body starts to make more because it thinks that there's not enough. So now you have 100 beta receptors, right? So now you decide, like a mom thing, I'm just going to stop taking my beta blockers. And now, instead of the usual human 50 beta blockers, you have 100. So if you have a surge of epinephrine, your heart is going to go so incredibly fast that you'll probably have a heart attack. Just FYI. So the other really interesting thing about receptors is, well, no, I won't go into that because you got enough stuff. Calcium channel blockers, which block contraction. Digitalis, which is an inotrope, and a chronotrope, which means it increases the contraction and it increases the time. It's for people in heart failure. Your mama is on this. Nitro, so what that does, again, when you're having a heart attack, the coronary arteries are contracting, maybe due to spasm, maybe due to clot, maybe due to whatever, and nitroglycerin actually dilates those vessels. It dilates a bunch of vessels. So you got to be a little careful as far as blood pressure goes. But certainly if someone has chest pain and they take nitroglycerin, they need to take their nitroglycerin. So stroke volume is another thing that's figured out by this calculation. And it's like, let's see, determined by venous return. Just something you'd have to look at. So heart failure is the inability of the heart to pump enough blood to sustain life. I would say that there are people who walk around with mild heart failure all the time and they're still alive, but valve disorder can reduce pumping efficiency. Cardiomyopathy, that's disease of the muscle tissue, myo, right? So that's going to reduce the pumping effectiveness. Like I said, it's all about being able to pump. You can have right-sided heart failure. Now, right-sided heart failure will often be secondary to lung disease because when you get lung disease, everything gets stiff back there, and it's harder and harder for the right side of the heart to smokers to get to pump into the lungs. It's saying also progression from the left side because it keeps backing up. And by lung disorders. So congestive heart failure is when it backs up so much that the heart may pump, like, someone like your mom who's taken digitalis, or my mom who took Lasix and stuff like that. Like, the heart muscle was definitely damaged. Their ejection fraction's probably low, but if you regulate the fluid, their heart can still pump the fluid effectively as long as they're not on fluid overload or whatever. So congestive heart failure basically happens when they are on fluid overload, and you can hear fluid in the bases of their lungs, and basically they're drowning. So they need to be pulmonary edema. You need to get the fluid, heart implants and artificial hearts. Okay, we won't go into that. Oh wow, they go through this whole anatomy. That's nice. Well, they're saying there is a space in the pericardium. 2-layered fibrous sac will lose between the lubricated space. It's not much of a space. It certainly isn't made for a bunch of fluid. Okay. Sorry. I'm looking right at my... Okay, this looks good. I think I covered everything. So any factor that affects heart rate or stroke volume could affect cardiac output, right? So an increased, very increased. So we went over that. A very increased heart rate or a very decreased heart rate can affect cardiac output, and anything that interferes with the amount put out during contraction, which can be muscle disease or valvular disease, right? Stroke volume, venous return, the blood returned. Blood volume, of course. Heart failure. Okay. So that's the cardiac system. I think you're doing the next one too. The next, I don't even know what that chapter is. Circulation in blood. All right, I'll be back for that one. Hope this helps, darling. Let me know.